Okay, we're recording. So good afternoon, Sharks. Thank you all for attending our telehealth case competition workshop series so far. We hope that these workshops continue to aid you in developing your research papers, but also develop you as young professionals in the pre-health sphere. Today's presentation will focus on the foundations of telemedicine and will be presented by our esteemed guest. So thank you again for being here, Dr. Bronsberg, and I'll go ahead and let you introduce yourself and get started on today's presentation. As people trickle in, I'll remind them, I'll keep an eye on the chat, and though this will again be posted to our YouTube channel later on. So again, thank you, Dr. Bronsberg.
Excellent, excellent. Thank you and welcome. I'm very excited to be here. The world of health informatics encompasses so many areas, and really, let's just touch on that first before we jump into the world of telehealth. So health informatics really can be broken up into three areas, and that's biomedical informatics, which is really that research end of it, if you will. There's clinical informatics, which is really working with existing technologies and developing technologies in the healthcare sector. So you could do anything from developing an electronic medical record to developing small devices to capture data, to collect on individuals. So you might be able to get that data electronically transmitted into some spreadsheets, and you can make some decisions on that individual immediately right there with their healthcare. And then the other piece is actually public health, and public health informatics is really dealing with the masses. And when we think of public health right now, the big target in the room, if you will, is COVID-19. So if we looked at how that data is collected on, say, vulnerable populations and how it is impacting those individuals, and collecting that data as it races across the globe, so we can target groups of folks and help keep those folks as healthy as possible, or avoid them getting contacted with with the virus. But anyway, the world of health informatics is quite large. There's so many different areas that one can get into. We can do a presentation on that alone. So, but that said, that kind of segues us right into telehealth. Telehealth is actually part of health informatics. So let me move forward. Second one. Let's see. There we go. Couple disclaimers I always like to do is I'm not being paid for this presentation. I mean, I am in kind of an odd kind of a segue kind of a way, if you will. I'm part of the university, so I work here for it. But I'm not being paid for this presentation. I am not plugging any, if I happen to mention a service or an organization, I'm not being paid by anybody to do that. So it just happens to come with the territory of what I'm doing. So learning objectives. At the end of this presentation, should you hopefully view the whole thing, you'll have a good understanding of what is telehealth and telemedicine. There is a difference between the two. We'll describe the different examples. There's 4 major examples of telehealth modalities, and we'll learn the practical tips on implementing telehealth. We'll explain some of the key barriers of telehealth, strategies to incorporate telehealth into a practice, a clinical practice, and identifying telehealth resources. There's some great resources out there. So, oops. My computer is just a little touchy today. Let's see if we can do that. Maybe that'll be a little bit better. Okay. So what's the difference between telehealth and telemedicine? HRSA, okay, we can look at HRSA's definition of telehealth. It's the use of electronic information and telecommunication technologies to support long-distance clinical healthcare, and patient and professional health education, health-related education, and public health, and public administration. So it's kind of like that big umbrella, if you will, and many things fit underneath it. And yes, you guessed, telemedicine fits underneath that, because telemedicine is really looking at that clinical delivery of healthcare. So it's actually getting out there. It's that clinical piece, if you will. So we have telemedicine refers specifically to the remote clinical services, the remote diagnostic treatments of patients by means of telecommunications technology. So we're using that communication technology. Okay, so the demand. What is the need for telehealth? We have a rapidly aging population, those baby boomers. By 2030, 71 million Americans, so something around 20% of the population are going to be aging. With that, they bring some other issues with them, if you will, health issues. As we get older, what comes with the territory? We run into health issues and health problems, and it's usually not just one problem. We usually have 2 or 3. We call those comorbidities. So we may have diabetes, we may have some heart issues, and it's not usually just one thing. If it is, I mean, wow, I mean, you have wonderful genes. Hold on to them. But usually it's multiple issues that you're dealing with. We have a large growing minority population. And I read somewhere recently, and let me look down here, it says by 2043, 50% of the US population is going to be minorities. So, with minorities, we have to start thinking about cultural competency, making sure that we're communicating properly, we're getting that information across. Now we're talking language, there may be language barriers. So you want to be sure that you're communicating properly. Resources that you have are dedicated, to those different groups of folks so they can get that information and understand that information. Rise of chronic diseases and rapidly increasing numbers of Medicare beneficiaries. Medicare, we have Medicare and Medicaid, and Medicare, usually for the most part, is those older individuals will fit into that category and utilize Medicare. And as I said, by the aging population, a lot of those folks, we have comorbidities. So we have more than just one illness we're usually dealing with. So that puts great demands on, they're homebound pretty much. So that puts other great demands on for some type of a telehealth or telemedicine intervention, if you will. So changing national demographics and geographic distribution of populations. I don't know if you've been keeping notice, but a lot of folks are kind of gravitating away from very populated areas and cities, and are going into the suburbs. And you have people in the suburb area kind of moving into the rural areas. Well, as we get into the rural areas, even the suburbs, even the inner city areas, we run into some issues where we have access issues for technology, infrastructure, and networking, telecommunications, and that can create problems and issues for people actually connecting and getting some of those services. That creates some challenges as well. So, but those folks are out there, and there is a demand. There's more of a demand. Then, of course, COVID-19 came into the picture and changed everything. COVID-19 created a huge demand globally for telehealth services, if you will. Here in the United States, a lot of legislation was done over the last year or two, allowing for many questionable services to be utilized for telehealth and telemedicine purposes. We'll talk a little bit more about that as we move forward. So let's talk a little bit about history of telemedicine, how we got here. Really, really interesting. In 1876, Alexander Graham Bell put a patent on the telephone. Way back in 1876, that's quite a while ago. Not too long after that, Dr. Hugo Gernsback envisioned the teledactyl. And if you look on your left-hand side there, you see that crazy contraption there, audio, video, but you also see that kind of like mechanical hand kind of a thing, gold colored, where that guy is sitting in front of, that's kind of like a teledactyl type thing. So in other words, it can actually feel and go out. anyway, you're looking at this. This is 1924. And you think about, wow, they really had the foresight to think of something like that. You know, fast forward to 2021, we're basically using all of that today in one way or another. So, wow, we've come a long way. But in this slide here, if we can fast forward a little bit to the 60s, and we look at NASA, and they were interested in, of course, sending folks in space to the moon, et cetera. They were concerned, you know, how are we going to work with these folks to be able to visually see them, not only for the work that they were doing with exploration, but also with healthcare. You know, these folks get into trouble, you know, how could we best assist them? So they poured a lot of resources into some of these technologies to make it possible. So kind of like the ultimate telehealth or telemedicine experience when you're at outer space. And we can even move forward a little bit further, which is another milestone, which was in 1967, I guess it was, where Mass General, which is about 3 miles away from Boston Logan Airport, actually did the very first communication with healthcare professionals on either end, if you will, using microwave technology and circuitry. So that was a milestone as well. Interesting history. There's another picture of that teledactyl. This is on radio news, which was on the front page there. So, you know, back in 1924 to where we are today with the internet and where that's all possible. So all very exciting, all very exciting. Another pioneer was Dr. William Eisenben, who created the EKG. Remember we said, you know, back in a couple slides back, we said back in 1876, Alexander Graham Bell invented the telephone, put the patent on it. It wasn't too long after, in 1906, about 30 years later, Dr. Eisenben, actually inventor of the EKG, did an EKG over the telephone line. So that again was another milestone in telehealth and telemedicine. Some of that earlier technology, if you look at it, is very bulky. It's tethered. So in other words, you have all those like strings, you've got wires, you know, it's plugged into the wall, it's plugged into the device, the device is plugged into a smaller device, and then the patient is wearing that device. So it's very, very tethered, if you will. And yes, we've come a long way. So some of the basics on telemedicine, as far as some tips, you know, keep in mind, really, really important to keep personal health information secure, compliant with HIPAA, the Health Information Portability Act, if you will. Really, really important. And those are like cornerstones of the protection of personal health information for folks. And we really, really rely on that. That said, and I say that because as we're moving through this, and we'll touch on that in some other different levels, but here, some tips. Ensuring and following standard safety guidelines just as an inpatient visit. So if you have an inpatient visit, you know, you're putting that data into the electronic medical record, you know, you're making sure that, you know, only the folks that need to see that information are the people that are seeing that information. So you want to have that same mindset as you're, you know, delivering care or services through telemedicine. So you want to really understand the license of and the requirements of your individual state. We've got telemedicine in all of our states, of course. You know, folks are doing that, especially with COVID-19. A lot of the laws have been relaxed, and folks are allowed to practice telemedicine and be reimbursed for it. But you need to understand the laws of each state is a little bit different. You know, in some states, being on the telephone and talking to a patient is not considered telemedicine as a physician. So those things really need to be taken into consideration. Of course, ensuring you're following HIPAA guidelines and security and privacy. creating a telehealth examination room. And you think about, you go into a room and you put a Zoom on and we can do telehealth like that. You need to take into consideration, are you in a room? Again, we want to think about personal health information and protecting it. Is it an earshot of folks just walking by to listen in on? We don't want that. We don't want somebody walking behind you as you're talking to someone else on the phone. Really, really important. So these things need to be taken into consideration. Basic training in telehealth systems. Folks that are working and using telehealth and these different systems that are out there, or electronic devices, digital devices, you really need to know how they basically work and how to work with them, because you'll be doing a lot of education with patients as well. So that becomes important. And what if something happens? You want to be able to understand where the issue may be so you can get it resolved quickly. Securing patient consent. You just don't have a patient, I'll call you next week and we'll do a telehealth. They need to sign a consent to be able to allow that to happen. They need to give consent for that. Educating the patient is critical. As you don't just Amazon or FedEx some equipment to someone and expect them to actually use that. Ideally, and really important and critical, someone should actually physically go there and show folks how to use that equipment. Truly, if you're looking for success with that program. Ideally, you schedule an in-person visit, or at least you're in that pattern of thought. That's what you're actually after. But you may very well go into a telehealth consultation, and that's perfectly fine. Cultural competency, as I stated before, really important. You want to be sure that you are communicating with the folks and getting your message across, you're understanding them, and a bit about their background, their history. That's how you, as a provider, depending on who you are, could be a physician, could be a dentist, could be radiologist, whatever the case may be. It's important to get that across, or a counselor even as well. So know when to recommend that the patient needs to come into the office. Really important. Some things, well, a lot of things can probably be taken care of via telemedicine. Okay. But sometimes those individuals need to come into the office, and you just can't rely on the telemedicine piece as a health provider. And that should be internally understood. All communications with the patients, again, you treat it just like an inpatient visit. Again, confidentiality, security of that information, entering, recording that information. You certainly want to do that. Preparing an emergency or a contingency plan. What if something happens? What if we're in Florida and we get one of our wonderful storms and lightning, and you get electromagnetic interference, and what happens is that creates problems with that connection and you lose connection. You have to have something in place. So you may have some policy where if in 5 minutes, if we lose connection and within 5 minutes we're unable to connect, call this number or we'll call you and reschedule a time for that visit. So you got to have some contingency plans in place. Really understanding your guidelines of your state as well, really, really important. Tele-etiquette is another piece of telemedicine. Really proper, and we started to get into this with, finding a good room to be able to actually do that in, quiet. You don't want people walking by behind you. You don't want me having a yellow tie on with purple smiley faces on it and green eyes blinking because it's totally distracting. So you don't want to distract the folks on the other end. You want to keep it as monotone as possible, if you will, as far as even your dress, the background of the room, et cetera, really important. So eliminate background noise. You certainly don't want that. Removing personal objects. Some things may be offensive to folks, and not a big deal. Just remove things and just have a pretty standard basic background, if you will, if you can. How do you convey empathy when you're doing a telemedicine visit? How do you do that? It's creating eye contact, leaning forward into the camera as you're talking or presenting. Moving around, not just staying perfectly still. I mean, that takes away a lot of the that connection with that individual on the other end. Okay. Types of telehealth. Telehealth modalities. There's actually 4 different ones. Whoops. Oh, come on. There. There's 4. There's live audio video, store forward, remote patient monitoring, and mHealth are the 4 basic modalities, if you will. So live, I'll tell you what, maybe I can do it like this. There we go. So live audio, it's kind of like what we're doing now. We're live, you see me, you can talk, I see you, we're back and forth, it's live, it's going on, it's synchronous, okay? But again, it's got to be HIPAA compliant, you have to have a secure connection with that individual. Some states, if you're on the telephone talking with someone and you're live, it's not considered telemedicine. It's got to be live. With COVID had changed a lot, and a lot of things have been accepted, if you will, that really aren't totally secure or totally in line with HIPAA policies and regulations. But in order to see the masses, because we had lockdown, we had a global lockdown, not only a national lockdown, but you had folks out there that needed to see their physicians, their healthcare providers for a variety of different reasons. So able to help meet that demand, the federal government allowed for some of these different mechanisms to be used, like Google Hangouts, Zoom, Skype, Facebook. However, you really can't use Facebook Live or TikTok or anything like that to make that happen.
Dr. Bronsberg, real quick, I got a question in the chat that I thought you'd want to be able to address, which is does an in-person visit have to be scheduled to fill out consent forms and other personal information, since you were just mentioning like how all these different platforms are being used right now? So are consent forms needing to be filled out in person, or
no, they can be filled out. You can give consent. You can jump on the portal and actually give consent through a form in a portal electronically. If you give consent due to COVID-19, a lot of some of those nuances have been laxed. So you can give consent a variety of different ways, electronically, through email, et cetera. So that's really not an issue. There's a way to actually make that happen. Given that, and COVID-19, as we move into the future, we make much more positive strides in the direction of control, vaccines, and all that start to come into play. Some of these things are going to go back to where they were, and it's going to be, now you cannot use Zoom or something else. For a telehealth consult, the restrictions will come back on again. As we get forward into the presentation, I'll talk about some of the things that are really lacking in the world of telehealth, although COVID-19 may have spurred on an interest to actually get some of that work done. It's still kind of it's been around for quite some time. It's never been truly embraced, if you will, in a very large, meaningful way in the world of healthcare until COVID-19. So
thank you.
Okay. Store it forward, just as it sounds. You audio, video, some image or data, you store it, and you go back to it later, and you retrieve it. And it's usually your healthcare team or your provider. When we start thinking about this, we start thinking dermatology, radiology, but even dentistry could be using this, or a variety of different other health professions. And what happens is, the team obviously looks at that information and gets back with the patient. So basically store it forward, and it's asynchronous as opposed to synchronous, if you will. And again, HIPAA compliant and security, really, really important as well. Remote patient monitoring, which is an area I find really interesting, and I've done some research in the area as well. That's a combination of this and mHealth, but remote patient monitoring is really using those digital devices to collect data, usually in the home, and we're able to, well, an example with chronic diseases, looking at glucose levels, looking at pulse ox, looking at oxygen levels in your finger, those little pulse oximeters you wear on your finger. Those are other areas as well. But you collect this information, you can send it, and even in real time, you can get responses back on those results from the healthcare team or provider or whoever that may be that's on the other end of that, nurse practitioner, nurse, which is really to me very exciting, because it's just like being there back and forth. But again, it's this stuff has to be secure, has to be HIPAA compliant, with all the regulations and the regulations in your state as well. But it's a very exciting area. Some of the different equipment that you may see, and you see it there with testing for glucose, and blood sugar, blood pressure, if you will. Couple of critical points with RPM, remote patient monitoring, is you really need to have a healthcare professional, community health worker, someone go out to the home and work with the patients so they really understand the equipment, how to use the equipment, and have some kind of a comfort level. And it may take 1 or 2 visits, whatever it takes, 3 visits. You need to do that truly if you're looking for success, and that person can actually use that in a meaningful way and get results. And the other thing to that is, again, that can be done in real time, which is really where the excitement is. And here's just some other quick picture of some other examples of that. Again, measurement and monitoring devices, evaluating specific health parameters for outpatients or patients in the home is usually what we're talking about here. This is a depiction of kind of the basic path, if you will, from patient to case manager on the other end, your physician or your healthcare team. You've got those monitoring devices. They could dump that information once they collected into here. They have an example. It's called a health buddy. That health buddy can transmit that secure and HIPAA compliant across the web. And it goes into some type of a holder device or data bank or a hard drive, if you will, which collects that information and routes it directly to the individual, their healthcare, their electronic medical record. So the healthcare provider, healthcare team, again, whoever's on the other end can look at that. This can all be done in real time. So in other words, it can be back and forth, which is pretty cool. mHealth is the last piece, is the fourth one. And these are mobile phones, tablets that you're working with. And I'll give you an example. I've done some research in the area of tobacco cessation, where I worked with a text messaging organization, and we sent a variety of texts to individuals with their consent, HIPAA compliant, all that stuff. We sent a variety of different texts. One was informational, one was supportive, and the third group of text messaging folks that were in that group got only 2 texts, a welcome text and a thank you text at the end. And this was over several months. So the group that got the supportive text and the educational text really increased their quit rates on using tobacco products or nicotine products, or abstain quite a bit from that, almost double of what it was without it. So very, very powerful, very powerful. Okay, there are different types of software that's used in the world of telehealth and telemedicine. Oops. All right, my computer is very touchy this morning. Okay, virtual visits. You know, again, that software is going to work with collecting that data, that information, storing that information. Again, everything is HIPAA compliant and security wise is of utmost importance. But it's grabbing that data, securing it, and that could be everything from medical data to financials to back-end office work data. So that's a separate piece of software. There's another software out there for remote patient monitoring, you know, that works with, you know, capturing that data, sending that data, collecting that data, sorting that data, you know, routing that data to the proper electronic medical record for that individual. Then, of course, there's a store forward software, which basically kind of does the same thing, you know, and stores it there for you. Now, that being said, in today's world, as we are moving forward in technology, you know, we're starting to see software that actually encompasses all 3 of those areas. By the way, these are all great areas to do some research in if you're interested. Okay, types of hardware in the world of telemedicine and telehealth. There's those carts, those workstations on wheels, and you see a picture of one over there on the right-hand side. I think everybody has seen one of these somewhere, even if it was on TV and you were watching some show and they had some medical segment in there or whatever. But these are pretty cool. They're audio, video. They carry a variety of different diagnostic tools for healthcare providers or physicians, practitioners, nurses, to be able to use with a patient right at the bedside. They're wireless, and they work very well. So it's really nice to be able to bring over an entire diagnostic outfit over to your bedside. There's a mobile cases, kind of like pack and go. I mean, here we have a variety of those mobile devices, and we saw a few of those earlier: pulse oximeter, stethoscope, all types of different pieces of equipment that we can use. Audio and video as well, to be able to do distance telemedicine if need be as well. And depending on how much you're bringing with you, obviously, larger or smaller, but they tend to be bulky when you're carrying multiple pieces with you like that. Handheld all-in-one devices do several different diagnostics with one small device, much more practical, if you will. That said, they usually work with tablets or smartphones to capture that data and send that data back and forth. And of course, wearables, remotes, watches. We all have seen the Apple Watch or the Fitbit watch, so we're familiar with those. They capture a bunch of different data points, if you will, everything from weight, blood pressure with some of those, and pulse and steps and all that as well, which we're familiar with. My computer is really, really touchy this morning. I don't know why, but here's some different, another picture of some different devices as well that you very well may have seen, and some strategies to incorporate telehealth into practice. There's a lot of possibilities. You can join a hospital telemedicine network, telestroke, tele-ICU, Telederm. There's a lot of different areas, incorporating outpatient telemedicine visits or consults, such as Telederm and Psych, conducting home visits with wearables and monitoring devices, chronic care management. That's a huge area, a lot going on there. Skilled care home-based programs for wound care, palliative and hospice. I work with a group of physicians here in South Florida that do wound care. And come COVID-19 in 2020, declaration of the pandemic, about 6 months into that, they did a 380, like almost everybody, and just jumped right into telehealth and telemedicine, particularly telemedicine and delivering care out into the community. And I had several of my students, graduate students, because they have to do a practicum, a hands-on practicum, work with this group to help get that up and running. So that was pretty exciting, pretty exciting. Did some great work with that. So it could, and you think wound care, I mean, what could you do with wound care? I mean, you know, it's a wound. I mean, you have to change the bandage, and there's more to it than that. You need to be able to monitor that wound and see whether it's progressively getting worse or better, or you know, how that patient is looking. You know, that all filters into it. So that telehealth component is an important piece. Independent health providers can develop virtual triage services, if you will. Lots of opportunity. The models, kind of business models, and how this might work, and if you can visualize this, hub and spoke is probably, you know, the most popular model, if you will. Think of a bicycle tire, and in the center you have your axle right there, and you have all your spokes coming out. Each one of those spokes at the end would be your little satellite, and that would be your how that looks visually, if you will. You can get creative and do it international or institution to institution. There's you know, very creative different ways that you can accomplish that. Barriers to telemedicine. There's a lot of barriers, even though COVID-19 came, and a lot of those barriers have been kind of washed away, if you will. Still, we have issues, you know, going into those rural or inner city areas, or even areas of a city or the suburbs that have issues with telecommunications and backbone and networking. They're not getting that bandwidth that they need. You know, the doc on the other end has to have a clear x-ray, or has to have a very clear snapshot, you know, of that strange little thing on your knuckle, so they can, you know, so the dermatologist can, you know, identify that as, you know, what that may be. Critical, but we still have areas of the country that are lacking, and so the costs can be quite expensive to bring up that ability to be able to do that. We have limited availability, high-speed communications, bandwidth issues, which fit into that. High-resolution images, yes, all very important. And I know you're thinking, okay, well, you got the building in a rural area, and we have the internet, and they are wired. The wiring may be an issue. And you have a buildings may be an issue. They could be in a mountainous area. You're just not getting that connection because you're getting it broken up quite a bit, you know, by a rocky mountain or wherever you may be. And that's where that issue lies. So how do you overcome that? You got to build little towers, and you have to have nodes throughout your place. Really important. We overlook that sometimes when we think we have the internet, we can get anything anywhere. Yeah. I go into my office at work, I can't even use my phone because I just cannot get reception. So, and God knows, I don't think those buildings are like 4 feet thick. I think they're, you know, a little brick, a little wood, and a little stucco. I mean, and still I can't get reception. So, I mean, it's a combination of that plus all the other waves that are bouncing around, and the iron and all that filters into it. Okay. Licensure, laws, individual states, we talked about it. Really important to understand that whatever state you're in. Lack of standards, this is a huge area. We have some standards for telemedicine and telehealth, but that's it. There's a lot that work that needs to be done in the states and federally at that level for that, for standards to be incorporated. Lack of evaluation of certifying organizations. We have certifying organizations, but we really don't have a dedicated telemedicine, if you will, or telehealth. And that's something that needs to be done as well. Malpractice, ethical and legal challenges. Think about, you're in a state and, okay, we passed telemedicine, we can do that now because we have got the pandemic going on. We want our docs to be able to, and nurses and whatnot to be able to service our folks that are out in the community that are kind of stuck where they are. Now you start thinking about the next state over, I have docs calling in and doing telemedicine service. The AMA over here is getting a little bit upset because they've got docs coming in from out of the state. And how does that work? And how do you bill for that? And what about taxes? And is that allowed? You run into all different types of legal challenges, if you will, that filter into that. And we're experiencing that right now. Okay, lack of sophistication on the part of the patient. And I said this before, that education of the patient is critical if you truly want success with that program, with that patient, if you want to be able to take care of them. Resources. There's a few good places to go for research. The American Telemedicine Organization is probably your premier, if you will. These folks, everything under the sun with telemedicine. It's a national organization. They do conferences as well, education. So it's something you can take advantage of and jump into. But the American Telemedicine Organization is a good resource. The other good resource is the National Consortium of Telehealth Resources. And if you look at the map there, there's a dozen of them throughout the United States. Here in the state of Florida, in that yellowed out area there where you have Alabama, Georgia, South Carolina, Florida, our telehealth regional center is in the state of Georgia. So they are also a very good resource if you're looking for information on telehealth, if you're looking for training, news, conferences. They are also a very good resource for you to tap into. We do have a telehealth advisory council. They have, I guess they're about 5 years old. They've done a lot of good work up there. Again, in rules, COVID-19, a lot of the stuff has been waived and accepted but there's still a lot of work that needs to be done in the world of telehealth. Interoperability is a crossover for everything, and that's something that certainly needs to be worked on. Whoops. Sorry about that. Yeah, and that just goes over that again. This slide here, I've got a couple of maps, if you will, of the United States. Since COVID-19, if you look at that upper map, you see, I don't know, a handful of states up there, kind of like a pinkish mauve color. I don't know what you would call that. But those states are the states that still have issues with commercial payers. And I'm talking commercial payers outside of the federal government or the state, or those type of programs, Medicare, Medicaid, et cetera. Those kind of payers. Your regular insurers, your like Blue Cross Blue Shield, for the most part, in almost all the states, it's parity. Whatever it costs, they will match that cost that they pay an in-person visit with a telemedicine visit. And that all came about, and if you look at the lower map and you see a lot of legislation has been passed, and almost all the states regarding payers and how these practitioners are being paid, these providers are being paid for those services. It's a big thing, to be able to, if the resources and the funding isn't there, it's not going to happen. It's like everything else. But COVID-19 really had, put it onto the table, front and forward, and we've moved quite a ways with that. I think as time goes on and we see more research coming out on the acceptability, the efficiency, the effectiveness, the cost savings. There's a huge cost savings with telemedicine. I mean, when you think about it, I mean, for me, I don't have to travel somewhere, wait in an office an hour, see my doctor, come back, half a day's gone already. If I can do that in an hour, whew, I'm in. If I don't need to, and I imagine most folks feel that way. I can't imagine you'd want to spend an entire day just going back and forth for just to see a doc. It's just not practical. So the savings there is huge. So in conclusion, telehealth, again, is that broad umbrella and things fit underneath it, including telemedicine. Telemedicine is really that clinical delivery of care. It's that delivery of care that we're talking about. Telehealth could be delivery of care, but it could also be education, it could be administration, it could be a lot of different things. Almost everybody is using telemedicine today in the world of healthcare to some degree. We're seeing a lot more growth in unique areas that you didn't think you would see telehealth or telemedicine. EICUs, remote patient monitoring is a huge area. Telehome care, it goes by a bunch of different names. But again, the key factors to that, to make that work, would be to go out and work with the patients and train them on that material. And the other key factor to that is it could be done in real time, where you can get back to that patient immediately on the results of what you're looking at the other end, the physician or the healthcare team. And there's still barriers that exist in the world of telemedicine and telehealth. Mainly, we still have some states that aren't paying parity, some of the insurers. Most of them are. We have issues of connections and bandwidth, which are really critical, especially for the folks that are dealing with visual stuff. You're looking at x-rays or, snapshots, radiology, whatever, dermatology, etc. Okay, I am finished with my presentation. It's a lot of information. I left out some information on the payer piece of it, because that can get a little bit depth into the weeds, and I don't think we really need to talk about that. But I think the snapshot that I gave you shows you just the different layers and different levels of telehealth and telemedicine. And hopefully that provides you with some food for thought on what direction you may want to go with your project, or at least the resources will give you some other areas to explore as well. Thank you.
Thank you so much, Dr. Bronsberg. I've gotten a lot of messages in the chat that say this has been very informative. They came in completely blank, and now they know a lot more about telehealth and telemedicine, and they're so grateful for your presentation. I actually have a really great question I wanted to throw your way too, where a participant asked regarding multiple barriers. In the event that there is no reception for a patient and they can't meet in person, what happens to them? I thought that was a great question.
That's a very good question. And I am not a practitioner, but I would have a contingency plan for that. And that plan would be, if I can get that person on the phone, I would certainly try and get them in at a different time, or maybe I can provide transportation for that individual to pick them up and bring them to a facility where they can get that that service, that care that they need. I would certainly, it would be a priority, because you would certainly not want someone to go without, that service, that care. So that's certainly one way of doing it. There's probably other ways of doing it, but that's how I would.
Thank you for that. And thank you again so much for this presentation. I'm going to go ahead and stop our recording, but I want to open it up for other questions for the audience. If you guys want to ask anything to Dr. Bronsberg while he's still with us during the presentation.